Thank you, Dr. Musa, for the kind introduction, and I would like to thank Dr. Ahmed and the committee who invited me to present this talk. So I will be presenting a patient-centered related outcome. So at the end of the presentation, we will realize that patient-related outcomes are not equivalent to clinical outcomes. It's an important domain that has principles, and it has to be done in a very specific and methodological way that to have it incorporated into the clinical practice. At the same time, application of patient-related outcome measures is complex, and research is needed to understand how to incorporate it into the clinical practice. Now, before I go and discuss about patient-related outcome, I want everyone here to think about examples of how patients interact with us. So these are a few statements that have been made to me while I was in the clinic. For example, I had a lady who had an iron deficiency anemia. She was very adamant about not using iron pills because they were causing constipation. At the same time, 3 days ago, I usually give my cell phone number for emergencies to patients. So a patient called me the next day after I saw her in the clinic. She had a provoked venous thrombosis, DVT, a simple DVT. So I started her on anticoagulation and so forth. And her only concern was, because I counseled her about bleeding risk with the anticoagulation, am I going to die from a bleeding? So, and so forth. So you can realize that even when someone has an acute leukemia, it's not just they're thinking about the overall survival or how the treatment is going to be. They are also thinking about how the social effect is going to be on their life. For example, I had a lady who had acute leukemia, and I'm discussing with her how complex is this situation and how grave the situation is. And she's only thinking about her family, that she has 4 kids, young kids, her husband is working. If she's going to be admitted for 1 month, who's going to be taking care of their children? So it's patient-related outcomes are not just clinical outcomes. They are different. Even when we talk about clinical outcomes, this is a comparison that was done between how physicians assess peripheral neuropathy in breast cancer patients. So if you realize, if you look at the first graph, clinical severity, majority of the clinician assessed the patient did not have any peripheral neuropathy. But when you compare it to the patient, how they assess the neuropathy itself, you'll find that there was a lot of discrepancy between how they perceived the neuropathy versus how the clinician did. So for example, clinicians were less likely to assign a severe or very severe score to the patient, while the patient themselves will assign that they had severe or very severe neuropathy more. And in addition, in this study, they added patient interference. So is the patient neuropathy is interfering with their social life? So also there was a discrepancy between how patients labeled themselves as severe neuropathy versus how it affected their life. So what is patient-centered research? So it's anything that is related to patient feeling, their symptoms, and any effect of the medical decision. And this is done without interpretation of any physician or any observer. The patient themselves are talking about their experience when they have the disease or they're undergoing treatment. So it focuses on opinion related to health, quality of life, or functional status, in order to identify patient needs and prioritize and creating opportunities to address them. Now, we do have definitions. The FDA and the European Medical Agency does have specific definition for this. And this is why the definition was put on, because they wanted to incorporate this into the clinical research itself. They didn't want only clinical outcomes. They wanted to have patient-related experience and opinions incorporated into research. Now, the way that we see clinical outcomes we see them at direct measures or indirect. So we have objective, for example, we do have studies that looking at overall survivals, or subjective, we do ask sometimes patients how they're feeling. So for example, anemia, is the fatigue is improving, and so forth. But medical benefit is beyond that. It's an umbrella which compasses symptoms, functional status, adherence to treatment, and satisfaction. And this is only just part of the treatment. So we have to look at what is the medical benefit and what does it encompass. It's not only our opinion that the clinical outcomes, but it also goes beyond that. Now, why patient-related outcomes is needed to be measured? It's a tool to improve communication between the patient and the healthcare service. So sometimes the PRO can be a sole indicator of a disease, for example, migraine. Sometimes it's not related to clinical outcomes. It's related to the effect of the treatment. For example, if you have antibiotics that requires patients to come every day to the hospital to have it intravenous, so that's an effect. Waiting time for surgery. So we know that, for example, in some countries, the waiting time for elective surgeries is 1 year. Someone who has hip pain, he's going to live with this hip pain for 1 year before he will undergo orthopedic surgery. And sometimes the PRO is a metric or indicator for patient safety. We know that in America, United States, the Medicare rewards hospitals who prevent falls in hospitals. So this is all considered to be PRO. In order to measure the PRO, we need to have specific tools or instruments. And usually these are questionnaires filled out by the patients. These questionnaires can differ according to the measurements, so functional status, health-related quality of life, symptoms burden. They can be general assessment or disease-specific, and the collection itself can be different between paper and electronic. Now, they are lengthy, so this is one of the forms that looks at the quality. So I've only presented only 16 items, but in fact, this questionnaire has 30 items. And I'm going to talk about the issues about the PROM or patient-related outcome measurement later on. So how do we apply it in oncology? So they did in RCT, where they systematically collected feedbacks from patients using specific questionnaires, and then they related to the team itself. So it's auto-generated, so it was a paper and electronic collection method, and they found out that those patients who participated in and filled up the PROM, they had higher health-related quality of life measures, they had higher treatment adherence, they avoided hospital admissions, and they have a higher survival rate at 1 year. So if PROM is very effective and can be used in oncology, how is the attitude of the oncologists in incorporating PROM into their practice? So this was a mixed method synthesis of qualitative evidence where they interviewed oncologists, and the results were some positive, some negative. So the positive was prioritizing, focusing on issues related to patients. So many of the clinicians said that they will not focus on issues unless the patient brings it to them, and the PROM was helping that. Also, some sensitive issues. So we know that there are a lot of questions by the patient themselves who are deemed to be sensitive, and they're not going to ask them unless they are prompted. So for example, one of the questions they were asked, how many platelets do I need to have to be intimate with my partner? However, clinicians differed on whether these informations were helpful clinically or not. So some of the physicians felt that it was already collected. They don't need to collect them themselves. And also they said that sometimes the patients, when they relate their experience, they were overstating them. And some of the problem with the PROM is that patients can convey information that you don't have solution for that. For example, we do face a lot of this in private sectors where patients complain about financial burden, and we don't have any solution for that. And the last thing was the sustainability. For example, if you are going to incorporate this system, is it going to be sustainable or not? Do you have the infrastructure to support that? So if some of the aspect that I need to emphasize is the issues when using PROM, validity. So you have a tool that can be reliable, can measure effectively, can respond to changes. The size of the items, so we know that, for example, the questionnaire that I presented had 30 items. This is a very long, and we know that the participation is directly related to the length of the questionnaire. Number of measurement of tools available. Unfortunately, the PROM that we have, the tools that we have here in the literature, it's very vast in numbers. So we don't know which tool to use. Costs related to the PROM, as I explained, that if you are going to use a PROM in your clinical practice, the collection data is going to need a data collector. You might need to have a face-to-face interview, so there's an extra personnel in the clinic with you. Feasibility, how you're going to collect them and store them. And then lastly is the culture adaptation. Every tool is validated in their own culture. So an English tool, or tool in an English language, you cannot really simply translate it to Arabic and say that this is going to have the same validity. So whenever we're going to translate a tool or a questionnaire, we need to be very careful in how to use it. Okay, so I'm going to go on and move. This was all theoretically wise, so I'm going to move on to a practical. So we're going to review, this is a paper that reviewed patient-reported outcomes in multiple myeloma trials. So they looked at 25 pivotal trials in multiple myeloma, and they wanted to know if these trials were collecting patient-related outcome in addition to clinical outcomes. Only 17 out of the 25 collected that. But they also noticed that when they measured the patient-related outcomes, majority of them used 2 measures, but also 1 in 10 used 4 measures. Type of measures also varied, so majority of them used QLQ 30, but also they used other methods. So the conclusion was there was some heterogeneity in using PROM in clinical trials itself. And this was affecting how a cohesive measurement process will be presented to clinicians in order to make a decision. When even non-offering treatment causes issues, so not everything is related to treatment. So this was a PROM related to watchful and wait. We know that in follicular lymphoma, we have watch and wait strategy. So how does, even the watch and wait, you're not offering any treatment. How does this affect the patient? Patients don't remember and understand watch and wait. They found out this was in prostate cancer. For them, watch and wait was doing nothing or giving up. This was some of the statements. The doctor never brought watch and wait versus treatment. You could do nothing, but I think you could have a problem later on. This was their understanding. If you watch and do nothing, your cancer is going to obviously progress. It's like, well, you're waiting for the time to explode. This is what their experience was when watch and wait was presented to them. Even patients' own belief will influence their decision. So when you're discussing watch and wait, and it could be the right answer, age has an impact. So the younger you are, the more likely you want it to have treatment or willing to have treatment. So when you're talking to someone who is young, it's different between someone who is older if you're offering watch and wait. There's also, they noticed that physicians themselves, although they were offering different options, some cues that patients were sensing from the physician that prompted them to be pressurized in not adopting watch and wait. So for example, one man was concerned about the side effects of aggressive treatment, particularly impotence, because the radiation involved in the prostate can cause impotence. And he was willing to have a watch and wait option. His urologist frowned when the patient chose watch and wait. And he decided he was forced to have radiation. Family pressures. So maybe watch and wait is good for you, but patients, when they went home, their wife, their family forced them to have a treatment. So these are all patient-related outcomes. Whenever we are discussing about how the decision is made in the clinic, it's not just patient and yourself who is taking this decision. There are other factors that can be contributing to that. Now, yesterday when I was discussing with my colleagues, I told them that I'm going to present 2 studies on allogeneic transplant that does not have overall survival, treatment-related mortality, and GVHD as an outcome. Now, this could be surprising because yesterday when we saw studies, all of the studies were looking at overall survival, patient progression-free survival, and so forth. But this is an example of a patient-related outcome that is not familiar to us because they're using different outcomes. So they looked at patient characteristics and transplant-related costs with financial hardship and measures. So they found out that your income would decline if you started as a low income in a low income bracket, and if you're paying for the cost of the transplants. For example, if you're paying part of the medication, and this is in America, so there's a reimbursement and plans, medical plans that goes into this issue. Now, your income is not only, the odds of ratio for income is not only declining, but also you are going to financial hardship. So they asked them specifically, if your income declines, are you going to face hardship? So for example, unable to pay rent and so forth. So again, low income, they had, the odds of developing hardship was higher. Paying for transplant costs was also 6 times higher. So these are not related to the clinical outcomes that we are used to, but patients are affected by that. Lastly, this is a last example. So does driving distance affects stress and impair physical function? Again, these are questionnaire. Again, in a transplant population, there's no overall survival, there's no treatment mortality. They're just looking at patient's characteristics and looking at whether they can cause stress or physical function. You can see that, for example, let's say long-term partner. So unable to have a long-term partner, your odds ratio will be decreased. Household incomes, again, low income will have more likely to have distress and more impaired physical function. The final remarks, patient-related outcomes are not equivalent to clinical outcomes. They are important to pain that has principles. And again, I showed you that application of this new outcomes measurement is complex. Research is needed to understand how to incorporate it into the clinical practice. Thank you very much.